Hello, you're listening to Do or Do Not. My name is Hadia Tariq. I am a fourth year medical student at the Alabama College of Osteopathic Medicine. Joining me today, I have Dr. Katie Davenport Gabonik, who is a family medicine physician with obstetrics training from Lansing, Michigan, who practices currently in Springfield, Missouri. Welcome to the show.
Thanks.
If you can take us through what a normal day looks like for you, you can start in the morning from when you wake up to when you go to bed and touch on the type of patients that you see on an average day and if you have any interesting patient stories to share with us.
I am a family medicine physician who works with the Coxell Family Medicine residency. So my primary role is teaching family medicine residents. And through my role there, specifically with my OB training, I teach the residents in our labor and delivery unit and our obstetrics team, as well as in the clinic. I'll attend for them in their longitudinal clinic as well as the maternity care clinic. And then as an osteopath, doing attending for our OMT clinic. So through all those hats and more that I wear, I actually am kind of more in an advisory role. So the patients that I'm seeing on a day-to-day basis are kind of in an overseeing, sometimes intervening, and I do C-sections as well. So I might be doing that. So I guess from a typical day on our labor and delivery unit, and we do have a very busy OB service, lots of complexity, both medically, obstetrically, and psychosocially here in the Ozarks. I could start, I guess, first of all, as a parent, getting up and helping my kids get ready for school. They have to be out the door by about 6:45, and I have in-laws who help that. I get up, get ready about 5:30, 5:15. I start with some yoga and just to kind of ground myself, get coffee ready for my husband and I, and then get my kids out the door. And then I need to be ready to go to be ready to be on call around 7 a.m. And we could have a C-section as early as 7:30 that also need to be in-house for. So while getting there, checking in with the residents, seeing if there's anyone laboring. Could have anywhere about 2 to 3+ laboring at any time. Scheduled C-section, I would go in with one of the residents who's interested in pursuing obstetrics training. And we have OB fellows currently, so an advisory role to them and an intervene if it's a complex case as well. And then after that, it's regrouping with the residents, any medical students that we have, and the fellow, going through our patient caseload for the day, those patients who are either laboring or on postpartum. And again, postpartum could be anywhere from 2+ up, and then their babies, if we're able to take care of them as well. So it's planning out their postpartum needs, their postpartum courses, if the babies need any circumcisions that parents want to have prior to discharge, and then rounding and then being ready for whatever walks through the door. So we also take care of patients who come in who need some type of antepartum assessment. So we have our OBED, and I can see anywhere, 1 to 2 patients up to like 4 or 5. It just really depends on the day and probably the moon cycle, honestly. It's very, very odd, but we just see patients coming in again through the day. If I'm over in our clinic, it's attending for 2 to 4 residents. They're doing OMT or again in their longitudinal clinic. So my day as a physician educator right now, and specifically in OB, probably looks really different than a typical day for someone who's doing family medicine obstetrics in a rural area or on their own with a group. So quite variable. And with the exception of getting up every single day to get myself ready and the kids and be ready to go at, about 7 a.m. And then you asked about a specific patient this week. When that question came up, I was trying so hard to think of something really unique. And I guess I can say again with our patients we have here in Ozarks. And so we have a lot of food insecurity here. We have a lot of poverty, a lot of chronic diseases that honestly will go hand in hand with those. So we have patients who have hypertensive disorders of pregnancy, gestational diabetes, lots of trauma in various forms. And so the complexity of care that they need is truthfully well matched for family medicine because we can see that and address multiple facets of their care. But it's amazing, truthfully, how people are really resilient and they can handle a lot of things until they can't. But it's a lot of medicine and a lot of psychosocial care.
I know it's challenging enough to just be a physician by itself, but then also in an academic setting, it sounds like it does really get quite hectic at times.
It's hectic, but truthfully, that's like the fun of it. I love being there with the residents and medical students and the fellows and just seeing their maturation, their confidence grow, and at least within obstetrics, it can get chaotic. Just seeing also how they adjust to that chaos and kind of regulate themselves and then regulate the area around them. It's remarkable. And I think that's probably my favorite part. Oddly, I like the chaos because I like to be able to see how are we gonna wrestle this in? How are we gonna work together and like work with what's available to like just again refocus and keep moving on 'cause it's a challenge.
That's definitely a strength because chaotic environments need people who work well in the chaos. So, jumping into our next question, we're going to actually switch gears a little bit. Can you tell us a bit about where you grew up and how you first became interested in medicine and decided you wanted to be a doctor?
So I grew up in, Lansing, Michigan, and I was there through oh gosh, I don't know, middle school. And then my family like transplanted out to New Mexico. So it was a huge culture shock, just a very big change. And I really, and this is going to take like a windy turning about, but I kind of latched on to basketball and became very enmeshed in that culture and was just like that was my outlet. And so I'm just played basketball and got really good at that. And then when I got to high school, I think it may have been one of my teammates or so, was just really getting into science. I thought that was cool. And so I took some of the classes that we were supposed to do and we dissected cats. And I thought, well, it's actually kind of cool. And I thought I'd be grossed out by that, but didn't. So really there was no like epiphany moment where I was like, I'm gonna be a doctor. It was just okay, I kind of don't bother. I don't mind this and I'll keep going on. And then when I got to actually in college, I was playing Division 1 basketball. So again, just stayed just true to basketball, and that was my first love. And then I actually within basketball again kept going on science training and became fascinated with my own physical health. And actually, it was there that I met the first osteopathic physician that ever treated me, and that was when I was like, this is it. This is the type of physician. I want to be a doctor. I want to be this type of doctor. And yeah, that was kind of the trajectory. So basketball kind of carried me along to that point. So when I was an athlete, I had a lot of struggles with hip pain, lots of knee surgeries, and I was getting disgruntled with my lack of response to traditional Western medicine with medications and physical therapy only took me so far. And then actually one of our team physicians who worked with multiple teams in the college, he was an osteopath, he was DO, and he did an osteopathic structural exam, did find some somatic dysfunction in my anonymous and my pubic bone, and just did some basic techniques. And over the course of several treatments, there was resolution in this pain that I had had for so long. And it just blew my mind that could happen. I mean, he was very thoughtful. He took time to explain what osteopathic medicine was and really just planted that seed to nurture and follow and tend to. And I just sought out more information about that as again going through my training in basketball and both in the undergraduate and college. And then that stumbled onto another person who knew another DO. And there is a doctor, Dr. Harold Magoon, who has since passed, but he was the one who kind of sat me down and said, this is what osteopathic medicine is. And I think his parents actually trained under Dr. Still. It was this incredible, I was like, are you kidding me? When I went to ATSU interviewing, I went to the museum, and there were some of his parents' class notes in the museum that he had donated to the museum. So it was like this dude just so historic in osteopathic medicine. And he gave me a lot of great advice and was very good person to have on the path to keep going on.
That's incredible to have that historical connection. I also wonder with how getting your medical education at a school such as ATSU, being one of the original DO medical schools in the country, how that influenced your desire to practice OMT as a physician.
Definitely the curriculum when I went to ATSU, KCUM was we had labs and we had this regularly. It was our osteopathic training was very hands-on, and then it was integrated into our classwork to think osteopathically. There are lots of other great kind of add-on classes to really delve into the mind, body, spirit connection that is, the osteopathic philosophy. And so it was incredible teachers. There's much in the Kirksville environment that just reminded you of that tradition, reminded you of the origins, and kind of give you that purpose. So this is what we're doing. We're carrying on this legacy, and this is why. So I actually lived in a house that wasn't too far from the graveyard that I actually walk up with my dog, and we'd go and like walk by like Dr. Still's grave and his family. That was kind of our regular route. It's everywhere there.
That sounds like a really unique experience. Now, jumping into a little bit of a different shift, how did you decide that you wanted to specialize in family medicine? And what are your favorite aspects of your specialty? And if you could touch on the application process.
This is advice I give to every student. So I'm also the director of student medical education for the ATSU students in the Springfield and Southwest Missouri region. And so this is advice I pass on to them because it was very true to my experience. I thought I wanted to do family medicine throughout med school, first 2 years in clinical. And I think that's also just a lot of, again, I think whether it be ATSU or osteopathic medicine in general, I think really encourages a lot of primary care. And so that was just in my mind, I'm going to be a family medicine doc because that's what we're supposed to do. And I got out to my first rotation and it was just outpatient family medicine. And then I'm not saying that is like a teach their own. It was not for me. I was like, what is happening here? I was not as stimulated. I was not as enlivened in just an outpatient practice. And that's just, again, my personality, and it's like teach their own. But I was so disheartened. I was like, this is what I thought I was going to do. And I feel not connected to this at all. Then you go through the course of other rotations and exposure to other specialties. And it wasn't until I got to my family medicine rotation that was in a rural setting. And this doctor, he did so much. He had his outpatient clinic. He rounded on patients in the hospital. He attended deliveries to do neonatal resuscitation if needed. He was like the medical director of their EMS. He also taught his kids basketball. He wore a lot of hats, and he had a lot of versatility and variety in his practice. And that's when became very clear, like this is it. This is the type of doctor I wanted to be. This is the family medicine doctor I wanted to be. So I share that with students. Say, like, even if you want to be this type of doctor, try going through it again, maybe in a different setting, to see if is there something about where you're at in your life at that time when you cross paths with that doctor or that place or that specialty, or if is it that attending you just didn't jive with. But just like try it again. Don't just say one and done and you'll never pursue it. There's just lots of different ways to practice family medicine and different specialties. So family medicine is what it was for me. And I loved, again, the variety and versatility of it. So I'm not someone who likes to sit still. I'm actually standing right now because I can't stand standing. So family medicine met that. There's just so many different ways, so many different stages of life to apply care to. And there's every single member of the family. And of course, people are complex. So we get to know all of them in that way for the medical and obstetric and psychosocial and all that. And so that's kind of where I landed on with family medicine. I wanted to have a lot of variety. And as far as the application process, you have to figure out like what you're looking for. So I found in my medical student rotations that I loved OB. Like I really struggled with, am I a family medicine doctor who wants to do OB? Am I an OB-GYN who wants to like actually talk to people and get to know their stories and like, if there's trauma? And I like, it was just really confusing. So again, had more OB rotations to kind of figure that out. And then it became very clear once I started looking at programs that there are some family medicine residencies that had a really strong OB training. So when my partner at the time, when we were looking at where to apply to, it was like we had to know what we were looking for. He liked a lot of inpatient medicine. He was kind of struggling with family medicine versus internal medicine. So we found for us what programs have what we're looking for, what we know about ourselves to be just drawn to, and then what offers that. And also, this is really, really petty, but I was like, I need to have a place with good pizza, a movie theater. He wanted to go hiking. We had to have caves. So we made like a little non-professional checklist for places that we were looking for that had those things we knew that we would need to be just all around well. So we actually went through the application process when they offered pre-match. So we were the last class to be offered that. So we applied as couples in various places and were offered a pre-match at the program that we're at right now. And that was a program that kind of, again, met most all of our check boxes of things we needed for professional development and for our personal well-being in the place. We wanted to be close to family, not so close that, but it ended up working out that way for us. But again, there was geographical features, clinical training features, and just personal well-being features that made that us find different programs that fit those criteria.
I like how you emphasize the importance of a holistic approach as an applicant for residencies, just how they evaluate us. We need to be looking at what's going to make us happy being somewhere.
We've seen a lot of students and applicants in the last several years who have questioned us in our program about what the wellness culture is. How is that supported? What's our wellness curriculum? And so that's been wonderful to hear. That's on people's minds as they know that going into this field, into this career, and this calling, you need to have longevity for it. And you need to have this whole self that's present there because all of that's engaged every time that you go to work. You bring things outside of work, inside of work, goes home with you. There's just a lot. So if you're able to know that you're supported in the workplace, and again, like I said, the chaos will come, like that's just part of medicine. But if you're in a place and with people who can support you through those struggles, not add to them unnecessarily, then yeah, you can thrive.
Going back a bit to your training, how did you decide you wanted to continue on to get a fellowship in OB? And do you think this is necessary? How did it add to your skill set? And why should a student consider getting this extra year of training as an FM resident?
It's a great question. And I hear this a lot in our students and applying to the program and interested in OB. Not every family medicine residency has the same OB experience as the same like inpatient whatever experience. So like when I went through residency, it was very, very heavy in OB. And again, it still is. It's just the nature of the region and the way our program's set up. So I started C-section training or identifying that I wanted to do C-section training as a second year. I was on my radar as a first year, but first year just is it's wild. So it's just kind of only bite off so much that you can chew. But once things open up a bit, I said, this is what I want to pursue. And during second and third year training, I was able to have ample numbers to go out and practice in a rural location without an additional fellowship. And that's the thing too, is different hospital systems may have different criteria for establishing or offering those privileges for C-section training or vaginal deliveries. So that's one aspect to consider if someone's looking at where they want to practice. Do they need to have so many numbers of C-sections or vaginal deliveries, tubals, et cetera, to be able to practice there without the fellowship? Because if they don't, then a fellowship's kind of a no-brainer. You gotta get that. For me, it was I had learned through only a handful of OB-GYNs and family medicine and OB physicians. And I also knew I wanted to stay within Springfield, within the hospital system I was at, because I wanted to teach. And in order to stay at the system I'm at and be part of the residency, I needed to have fellowship training. So that was okay, this is going to help me stay here. And also I wanted to learn from other physicians, other surgeons. So that is what I tell people. Like if you do 12 C-sections, you do 12 C-sections, but there's so many different ways to do a C-section. There's so many different presentations of patient anatomy, of decision to make us to intervene with a C-section. There's so many factors. So you're going to learn something every single step of the way. Every single 20 C-sections to do is something else is going to come up. So best to have equipped skill set equipped to navigate complexities and know again when you're out of your league and you need to get some additional hands in there or when to say this is not appropriate for me. So I just need more exposure, wanted more exposure. So during the fellowship, learned from so many different OB-GYNs that had different techniques. And it was so wonderful because they're like, some people will be very straightforward and here's the evidence for this. And some will be like, there isn't evidence for this, but this is the way I was trained. So this is why I do it. So it was just learning different approaches, getting down to, again, what's the evidence for so many things that are done, more repetitions in the OR, and then again, just learning different techniques. So I still remember, I mean, it was truthfully the best year of my life because it was just this is all I was doing is learning and getting involved with as many C-sections as possible and some things that I wouldn't see, but they just wanted to show that, again, more anatomy and more approaches. So for people who are considering it, I would say check with what your institution or where you want to go to. Do you need it? And also, even if they don't need it and you've got the numbers and you want to just submerge yourself in that type of learning environment, because that might be how you learn best, which for me, that is just complete immersion, and go for it because it won't be something you regret. Like it's just adding more exposure and experience in truthfully a very protected way when you are still a learner, because there is a transition from when you're just the learner to when you're the doer, when you're a resident to an attending. There's, no matter how much confidence you come out with as a graduate, there's a reality check when no one's behind you giving you the, yeah, you got that. You're just kind of thinking, I got this, right? Like, and so it's just it was another year of just that. And some people don't need that. So that was just me. So when we talk to students who have an interest in all things and they can't narrow it down, but they know they want to do OB, but they also like kids and they also like geriatrics, it's like, great, you're talking family medicine and you need to have some OB training. Because another thing is when I was a med student who was talking to an OB-GYN on one of my fall OB rotations about my struggle. Do I do a family medicine with OB or just OB? And she was very clear. And she's like, if you're going to do a vaginal delivery, you better learn how to do a C-section because it can go very quickly south and you want to be able to do what's best for patient care. So if you're going to be out in the middle of nowhere, practicing rural, and your backup surgically is 30, 40 minutes away, or that may not be enough time to have the best patient outcomes. Again, I said in Springfield and in our program, we see a lot. And so I can see just in the 10 years doing this, like how quickly things can go very, very chaotic. And it's a patient safety issue. And it's a relief to know that I've got skill sets that can start. And if I get to a place where I am uncomfortable, I've never seen this before, even after 10 years, I've got backup that's nearby that can help. And then I learn from them. If this ever were to happen again, how to approach it. It's a lot of things, a lot of factors that go into that consideration of whether or not to get a fellowship. And then just as one other piece there is there's no saying you can't go back. So if you graduate residency and you find out later that that's a fellowship that you want to pursue, you apply. And had one of our prior faculty who went on to do an OB fellowship after I don't know how many years in FMOB with just vaginal deliveries. And then they're now doing C-sections at another program. So it's just the door is always open, I guess is what I'd say. So teach their own, whatever pathway they choose.
That's nice to know that there's a bit of flexibility for people who maybe don't want to do it now or are a little hesitant, but I like what you said about that idea of a safety net for your patients, but also in terms of confidence for you, knowing that you have this additional training, you know what you're doing, despite the natural fear that comes with something like that. What unique perspectives do you think having family medicine and an osteopathic background brings to your patient care? And what advice do you have for medical students applying to OB-GYN as a specialty and family practice with an extra year fellowship?
There's something about our osteopathic training that is so special, and it sounds so simple when you bring it down to like we're trained to look at the patient before us, the human being entirely, mind, body, spirit. We learn so much medicine, we learn so much care, but we also learn how to apply it and when to apply it, and also to listen to when it's the right time to apply it or when it's time to pull back. I'm just thinking of some pretty intense deliveries we've had recently where there's a lot of chaos. There's a lot of things that are going on, and we get very fixated on managing the medical realm, the medical complexities and complications and what, right? So we're trained there. But then I see the osteopathic docs who they recognize, yes, we're doing this, but we need to check in on our patients. How are they mentally, emotionally processing this? And not just them, the people who are witnessing this. Is their partner okay? And so they see this. We, osteopathic physicians, I think we're trained in human medicine. And so we see how, yes, we can do medicine, and also how can we do it humanely and to take care of, again, the mind, body, spirit, because while the body might heal, there's still some emotional, mental, spiritual aspects that if those aren't tended to, or at least just recognized as a necessary component in someone's healing and processing, we're like missing the point. And so I appreciate that in our training. And I would say if anyone's here again, I'm here a lot with our students who are in the region who come from osteopathic training. They're comparing themselves to students who are in allopathic training, and there are wonderful physicians in each. And I keep reminding them, like, you're trained every single day in the classroom in this realm to think of the person before you as this whole person. That's, you might take that for granted, but that's really, really special. And truthfully, that's what really helps connect people from the physician patient standpoint in genuine medicine. And again, I'm not saying that our allopathic partners don't grasp that. They aren't reminded about, they're ingrained in that every single day of their training. So we have that as it's kind of a conscious and unconscious, just reiterating that. And so for physicians who might be considering going to OB/GYN or family medicine with obstetrics, again, if that's a component of the care that you want to have, and I know some great OB/GYNs who I'm like, you're a family medicine doctor, you just don't know it. Like you've got the bedside manner, you've got great, and they just maintain that part of who you are through your training, because there is different, I keep saying the word culture, but that may be the best word I can think of right now. There's different ways we're trained. At least in family medicine, again, we're trained on relationships and across all age ranges and family units and whatnot. And then in OB/GYN, fantastic what they do, right? It's gynecologic, it's obstetric. There may be that missing element sometimes of the whole person care. So for those who are hoping to maintain that, do it, because it does make a huge difference. I can see in both in the physician who maintains that authenticity, if that's who they are, when they're in practice and seeing lots of patients, and their patients recognize that and they're drawn to that. I don't know if that answers the question. I guess just stay true to your heart. That's such a cliche thing to say, but truthfully, it is one of the most important things you can do is just be who you are and whatever path you choose.
Of course, there is a lot of overlap between the two specialties when you bring in the OB component, but they are distinctly their own at the end of the day.
There are things that an OB/GYN can do that I need them for. And there are things that a family medicine doctor can do that an OB/GYN needs them for. So we have our limitations and we have our strengths, and or we are aware of those and can work together for patient safety and outcomes.
Okay, so speaking of family medicine, can you share with us some of the work you've done with establishing the lifestyle family medicine residency program, and what does that entail compared to a more traditional FM program?
So I have to give all credit to my partners, Dr. Christine Cameron Crimes, who are at this point the main people of the lifestyle medicine residency track at our family medicine program at Cox Health. They've already sat for their boards, and so they're pretty incredible. I'm just starting that process right now, but I feel like have been practicing that way for probably longer than I recognized it was even a thing. So the lifestyle medicine recognizes, encourages, these foundational pillars of health for all well-being. So stress reduction, avoiding risky substances, optimal rejuvenating sleep, social connection, physical activity, and then of course nutrition. So we hear that in our upbringing in both undergraduate medicine and then in some programs in family medicine. We just don't learn how to apply it. You can tell, like someone saying, I'm struggling with sleep, and we're told, say, CBT, and maybe getting a routine. It just doesn't have a lot of bulk to it, or at least that we don't learn the why. And it's just one of the many other things that we're learning. So lifestyle medicine is, again, getting back to here's the evidence for supporting these recommendations and encouraging people who, again, we're complex beings to get more to the encouraging us to understand our behaviors that are contributing to it. Because it may be that someone doesn't have a quick fix for their inability to sleep because they've got so many other things in their life that are contributing. So again, it's just giving space, have that conversation, and then work through it together and empowering people to make some changes for themselves. So it's not all on what our role is in fixing that. So I guess that would be the big thing. It's empowering. The lifestyle medicine approach in that residency training curriculum is to help us who have the knowledge to know when to apply it and to help people, I guess, find in their own lives what things are contributing to their health, as opposed to traditional way we're taught in family medicine. We're like reminded that that's a part of it, but then we've got this huge algorithm of 15 other things that we should be doing. So it's like we have this little wedge of possibility to intervene from the lifestyle medicine and behavioral change. But the most of the pie that they teach us out in family medicine residency is this medicine and then refer to this person. And again, just more things that I think are very physician centered or healthcare centered when a lot of the problems may be more again stuff things that like part of our control. So the lifestyle medicine residency curriculum can be adopted in so many different specialties: OB-GYN, peds, IM, family medicine. And it's there because it can be applied to everything because it's human care. And see, after doing family medicine traditional training for the last 10 years and always having that little osteopathic flicker of what would Spill say about the lifestyle medicine now coming in and seeking that training out and getting that really like, this is the way, this is how we help turn this ship around because the fixing that we've been trained to do has limitations.
I like that. It's kind of giving power back to the patients. How can you take control of your health, especially in a rural setting where sometimes that's all you can do?
Sometimes with urban, when there's too much and you think that you've got 15, you don't need any of these. Just because they're available does not mean that they're indicated. So resource rich is also an issue.
Actually, that reminds me of an article of yours that I read with the Springfield Business Journal about quote unquote food as medicine, which I love. Can you share with us your philosophy on this holistic level of care and how, like you said, the idea of AT still and osteopathy influences that?
This food as medicine movement, I feel like I'm kind of jumping on late, but again, it's been going. But after I'm in, I'm like, oh, this is it. This is very Mandalorian. This is the way. This is it. So we need to eat, obviously, and there are different ways of eating. Our standard American diet is so deplete in nutrients, fiber, good plant-based proteins that what people are consuming on a regular basis is so nutritionally depleted. Our patients, we even are not getting the nutrients that we're intended to get to fight inflammation, to restore our immune system, to actually contribute to better mental wellness. There's just so many things that there's a wonderful paper from the Rodale Institute. It's their white paper, which just blew my mind. So that would be something I'd recommend anyone to read as far as how even just farming practices have changed the quantity of the nutrients in our food and the quality of it, and how to get those nutrients back, we have to have good practices to make these fruits and vegetables and grains as nutritionally dense as possible. And there's so much evidence and so many various studies about how lifestyle medicine, whole foods, plant-based dietary patterns, starting those can help reverse many chronic diseases, coronary artery disease, type 2 diabetes, high blood pressure. I mean, things that we face on a daily basis. So it makes sense. We're not going to be fighting these problems with the medicines that we've been trained to learn about. We're going to prevent them and treat them with the things that are available that have been grown to be nutritionally dense and help our body give it the fuel that it needs to do what it can do. It's like, and then there comes in the osteopathic philosophy, right? So the body is a unit. It can heal itself when put into when things flow, when lymph flows, when blood flows, when the inflammation of that restriction is resolved. It's improving our body to function as optimally as it can. And so it's just reminding people that that's an option, and it's making that more of a conversation as opposed to starting right off with pills and starting right off with interventions that only go so far. I remember Dr. Jason Haxton, he's the main guy, for lack of a better word, of the museum up at ATSU. And I remember him giving a presentation at a osteopathic conference just about Still's philosophy too of good eating. So, I mean, this is just basic human needs, yet it's not something that we're familiar with because we grow up with it. My kids know Burger King jingles. I don't take them to Burger King, but it's just around. And so it's so in our face and in our ears, and it's so familiar and more familiar than. So that's where, again, I'm going off the rail there, but like food is medicine, bringing it back. This is why, this is what carrots do. Or, okay, you don't like carrots. What do you like? And, oh, you like that. So let's get more of that in there. And do you know that this actually is contributing to your pain because it's got these building blocks, these kindling that will actually make that pain flare up. But we just aren't trained in that. And maybe your curriculum is different currently. We'd love to hear that it is, but we just learn about things that diet and nutrition are like a little fraction of what we learn in medical school. But really, that's truthfully what we're seeing with evidence emerging that that's the foundation of so many of these diet-related diseases that, at least in primary care, we keep seeing every single day. And it gets really, you can only do so many things the same way.
Is it like madness is doing the same thing every day and expecting a different result?
What we're seeing. And that's where, again, lifestyle medicine, food is medicine comes in. Because it's like, this isn't working, y'all. We can do better. To me, this is better.
I love how you vocalize that because it's true. It's as simple as you are what you eat. You all have to eat food. Taking in the osteopathic approach into food as medicine and how you tied it into the tenets of philosophy, I just find that very inspiring. So thank you for that.
Still had it together, that guy.
You knew what he was talking about. Speaking about wellness, I wanted to talk with you about your interest in yoga
Yeah.
and if it's paralleled or intertwined with your practice of medicine in any way.
So this is kind of a funny story. My partner, so Christy Crimes, and she's one of the lifestyle medicine starters up in our program. So we became so frustrated with our patients not being able to access physical therapy. And these were patients on Medicaid. At the time, Medicaid was not covering physical therapy. And we were like, this is ridiculous. Come on. So we're like, well, we can't go be physical therapists. And honestly, if some of our osteopathic training, I was like, I think we could do some of this, be yoga teachers. And so we just got a wild hair and looked into yoga schools around town and found one and signed up for training. And so we got our 200 hours of yoga teacher training. So we're both registered yoga teachers. And I went in there with this mindset. I was like, I'm going to do this for my patients because they need this, or they could benefit from this rather. Well, what I found, like many things, right, when you have an agenda and then life really tells you what's up, I found for me that it was my healing, and it was something that brought me to see a different way of community healing and body healing. I was also reading a book at the time called The Body Keeps the Score, which I will shamelessly plug right now, is probably one of the best books you can read from trauma and body, and we get mind, body, spirit understanding there. And so I found going through that training, I was personally discovering something. And then I found too with OMT, some of these yoga poses, this is just OMT in a different way. This is whoa, whoa, whoa. It's all connected, right? So I was like, okay, this is fitting. So then some of, when we find something on an osteopathic structural exam, I'm like, okay, so we can adjust this and we can do some OMT now, but at home, here are some yoga poses that I want you to do that will start addressing what we found on the exam. And then of course doing it bilaterally so that there's balance. And then also from, wellness and so much stress. So it's teaching, first learning, and then teaching grounding practices, mindfulness, breathing techniques that that our patients can use, that I use truthfully, even in, stressful environments. I learned how to ground myself. I learned how to breathe. I learned how to let things just kind of evolve without intervening if it's not the right time. So it's those skill sets and that term practice, like that was very applicable in my own role as a Western medicine. And then also again, just seeing how people, when they and myself, into the tissue. And also we probably see this a lot in OMT. You're doing some treatment and then all of a sudden someone starts crying and there's that abreaction or that release. And then like, what is happening? So I just learned that happens. This is why. And then how you skillfully hold that space for whatever needs to occur without either doing something too soon or too late that might actually contribute to more trauma or more hurts. So again, a lot of similarities with each other. And I put it on my 10-year plan to find some way to integrate yoga into OMT for those who want to go forward and be trainers and teachers, because we do a lot of similar things, just different approaches. And again, we're speaking the same language. We're saying similar things, just different dialects, I guess. So I went into it for my patients. I came out of it with so much for me and just a new way to see how incredibly resilient people are, and found some hope and again empowering people to get into their body and be okay with that, and again to use their breath to face whatever's occurring. Power to the patient, empowering people to be equipped with many tools in the toolbox to face the complexities of life.
As someone who also fully believes in the healing power of yoga, I love that. I think that's so cool. And I hope one day to also find a way to somehow incorporate the ideas of yoga into however I may practice. So that's awesome. Kind of shifting gears a little bit, I want to know what you think is one of your quote unquote superpowers that has helped make you successful.
Just to go along with yoga and the mindfulness practices is being present. I know when there's someone who's struggling, at least from, patients, there is a huge shift when I give them my forward-facing body, when I look at them, when I show that I'm hearing them and acknowledging whatever is going on, acknowledging their presence. It's a very simple thing, but anyone can do it. It's just a conscious decision to, I'm going to be here for this person. I have no idea what's going to happen, but I'm going to be here and be open and just share that, because that's all I can offer sometimes. It reminded me where they even come from. And I think there is a lot of the yoga training and a lot of mindfulness training that contributed to it, as well as there is this book when my kids were younger. It was, trying to get these philosophical books in front of kids sooner than later, than more so than some like dog who followed a kid to school, which was still kind of cute. But I was like, I don't want my kids to be deep and big thinkers and kind. It reminded me of this book. It was Leo Tolstoy's story about the three questions. And it was the three most important things are, so the most important time is now. The most important person is the one you are with. And the most important thing to do is to do good to that person. So it's just showing up, being present, giving your attention, and really wanting what's best for that person, and what's ever in your power to help them with that, do it, right? Our paths cross for a reason. We don't know why, but we're here. So I'll give you all that I am, and just know that I'm here with you.
I like that. I've never heard of that book or those questions before, but I really like them. I think they're really reflective. So that leads us to our final question for the day. What is a piece of advice that someone else gave you that has influenced you and you would like to pass on to our listeners?
Well, one of my wasn't really shared directly with me. It was actually shared in a presentation. Dr. Logan Banks, was one of our former faculty. He was an ATSU grad as well. He and his family went out to Burundi, practice rural medicine. He's the first DO to be credentialed there. And he does obstetrics. He was actually our first OB fellow at the residency. He's followed his heart. It's landed him out in Burundi. And he comes back occasionally to just present on, here's what's happening there. Here's some interesting cases. And I'm also going to just share some of the culture. So he shared this proverb that translated to, if you want to go fast, go alone. If you want to go far, go together. And that resonated with me because I can recall as an athlete, I mean, I'm this like 5'4" pesky little thing. Like I don't know how I got into a Division 1 basketball terrain, but I was quick and I was tenacious and I was just this ball of energy. And I remember when my coach was like, you don't have to go fast all the time. You can slow down. You have to pace yourself. You have to shift gears. That's actually a skill set. It took me a while to realize that. And I can think of Dr. Magoon, who gave me some advice on pursuing osteopathy. And he even told me, just hold off, just go explore the thing, see if this is what you want to do. But he pretty much gave me advice I really didn't like at the time, which was to slow down. And I can see all those sayings, or at least those that advice that has kind of come up in different ways throughout the years. And that proverb just pulled it together so well as you can go fast, and sometimes you do need to, but fast all the time is going to burn you out. And also, it just leaves you alone, really. And so, at least we learn in family medicine again, relationships and in teaching, it's about the next generation. It is about elevating those that will continue the journey on. So it is giving yourself to something bigger than you are. And that's what that gives. It's like figure out what it is that you are connected to that's drawing you forward. Because if it's pulling you and you're draining and you're alone, it's not the right thing. But if it's pulling you and you're getting more energy and you're growing and you're connecting with people, follow that because that's going to have something that's sustainable and not just about you. That's, again, it's what helps the next person right next to you and doing what's best for them and doing right by them. So, not saying don't go fast ever, you got to go fast, but you also know when you have to have your team with you, you have to have your partners, you have to be on board with the patient, you have to slow down and have those conversations with people because that's how you move forward together. And so yeah, that would be the one thing. It's beautiful. It's so applicable in so many ways. Us all doing this together and helping each other out.
I really like that. Dr. Davenport, this was a really lovely conversation. I enjoyed speaking to you so much. Thank you so much for joining us today.
Thanks for having me.